Hello, Assalamu alaikum, and welcome to Baby Step Med, where I try and make difficult medical concepts a bit easier. Welcome to the first podcast. I feel like this is a really depressing topic that I chose for the podcast, but I felt like I needed to explain this because this is a really hard topic, and there's not much information, and we really aren't taught palliative medicine in med school as much as we should. So I'm just going to go over some really high yield points, and just hopefully after listening to this you guys will have a better understanding of palliative care and the protocol that we use and the algorithms that we use for palliative medicine. Okay, so first of all, what is palliative medicine? Palliative medicine is basically end of life care. If somebody has a terminal illness, they are referred to hospice care, which is a specialized center that deals with their emotional needs, their pain relief, their feeding needs, and everything else. So this is really important. So now let's get into some really common scenarios. So if a patient has pleural effusion, okay, imagine a patient with lung cancer or a background of COPD, and their stats are really bad, their oxygen saturation is really, really bad, and they're having difficulty breathing, and now you're supposed to help them breathe, okay? You can give them something, medicine, or you can do something to relieve the pleural effusion. So what you would do in this scenario is you would give them a therapeutic pleural aspiration that will make it easier for them to breathe, and instead of giving a medicine. But if the patient has a pleural effusion and they're bedbound and they're literally about to die, then you would obviously not do a therapeutic pleural aspiration, because then it will just cause them more pain, and at that time you do not want to do anything interventional. You just want to make it peaceful for them. And if a patient is on that stage where they're about to die and they're having the death rattles, they're having a lot of secretions in their mouth, and you can hear them breathe really loud, and with you can listen to death rattles. If you YouTube it, you can listen to it. It's a very specific kind of sound. In that case, there are options that you could do, but the thing that we do in palliative medicine is that we dry up the secretions, because the patient is very weak, okay? They don't have a normal cough response or breathing response. So if you do anything interventional, like giving them nebulization or sucking up the secretions, that would be very painful for the patient. What you want to do is you just want to dry it up, because if you give them nebulization, what will happen is that the mucus will become thin, and it'll just cause more congestion for the patient. So you do not do that. So the pleural aspiration is for a patient who is terminally ill, but they are not so sick that they're bedbound and they're about to die. Okay? Again, the goal is to make the patient comfortable. Okay, now we're going to look at a patient who is having sleepless nights and they're having anxiety. Okay, they're having insomnia and they're having anxiety. What you would do is you would give them a benzodiazepine, which will help them relax. And because this is a terminally ill patient, we do not worry about them getting addicted to the benzodiazepines. However, if this was a non-terminally ill patient, we do not give them benzodiazepines as a first line. We give them zopiclone or something else, depending on the cause of their insomnia. But for a terminally ill patient, you give them midazolam subcutaneously. Okay, this is another important thing. In a terminally ill patient, a patient on palliative care, you do not give them any medicine via the IM route or the IV route. Reason being, you do not want to stick needles into a patient because it is a very uncomfortable thing. So the preferred mode is oral, sublingual, or subcutaneous. Subcutaneous is because the location is mostly on the stomach, on the abdomen. So what happens is that their hands are free. Otherwise, if you give them IV, it's usually in the hands and it's more painful. So the subcutaneous route is preferred in a palliative patient. And the subcutaneous route, they're given a syringe driver for pain and for other medicines, because then they can control the syringe driver for themselves. So they can give, if they're in more pain, they can crank it up and they'll get more morphine, for example. And you just give them a little bit more control over their pain relief. Okay, now if you think about a patient who has cancer, okay, and it's at the terminal stage and they're having bone mets, okay, what is the best treatment for bone mets? You would think it's medicine, but no, it's actually radiotherapy. Radiotherapy is the best relief for bony mets, and it takes a few weeks for it to be effective. Before that, in the first couple of days, like 1 to 5 days, it's going to get worse. The pain is going to get worse. Because the pain is going to get worse, you're going to have to give them another medication just to bridge the effect. In this case, morphine would work, or an NSAID would work. Okay, you do not give them bisphosphonates for the bridging, because bisphosphonates also take a few weeks for them, or a few months actually. It takes about 6 months for bisphosphonates to start showing effect. So you do not give them bisphosphonates for bridging. You do give bisphosphonates if the patient is having pain or confusion due to hypercalcemia. Then bisphosphonates is the first line to go for. But for bony mets, it's radiotherapy. Okay, and obviously you will look at if the patient is allergic to NSAIDs, then you would not give them an NSAID like diclofenac or naproxen or brufen. Okay. And the pain that the patient experiences after radiotherapy is called bony flares or bone flares, because the pain is flared up. Now, if we talk about pain relief, if the patient has stable pain, then you can go for patches, because they take up to 3 days for it to show an effect. So you can't really, if the patient has unstable pain, you can't really see if it's making an effect or not. So we do not give patches for unstable pain. For unstable pain, morphine is the best medicine. But if the patient is having a lot of side effects due to morphine, then we would go for codeine, because codeine is given in a less dose to have the same effect. I specifically have a video about palliative pain control on the channel. You can just search palliative pain control, baby step med, and you can find the video. Okay, now if a patient has liver pain, okay, if they're having pain because of swelling of their liver capsule, neuropathic, because the liver does not have nerve fibers. So what you would do is you would give them something to decrease the inflammation, and once that inflammation is decreased, the pain will also be better. So you give them NSAIDs or you give them steroids. Now I'm going to talk about nausea and vomiting. The treatment depends on the cause of the nausea and vomiting. So if the patient has, so we just look at the cause and then we treat them. Okay, so if it's because of a metabolic reason, if they have a kidney disease, that's why they have a metabolic problem, or it's because of a drug or toxin induced, then you're going to think about, okay, this patient has a lot of metabolites, so you're just going to go from high to low. That is the goal. So high to low, H and L. H for haloperidol, L for levomupiromazine. I also have a video of this. You can look it up on the YouTube channel. But I'm just going to give you a really quick overview just so you know. If it's because of radio and chemotherapy, because if it's radio and chemotherapy, they need peace, and peace is achieved through yoga, and in yoga you go O and Om. So OH and OM. O is for odansetron, H is for haloperidol. Again, OM, odansetron metoclopramide. How do you remember that? H is in radiotherapy because H for headphones. You wear headphones to listen to the radio. Okay? If it's because of increased intracranial pressure, then you gotta decrease it. Okay? D and C. Dexamethasone, cyclizine. If it's because of a bowel obstruction, then you're going to imagine that a train is stuck in bowels that's causing the obstruction. So it's going to be, and the train goes choo choo. So you're just going to remember CHOO, C for cyclizine, H for hyoscine butylbromide, O for odansetron, and O for octreotide. If it's because of delayed gastric emptying, you're going to think about, okay, delayed DM. D for domperidone, M for metoclopramide. If it's because of ENT causes, or if it's because of ENT causes, then you're going vertigo. Then you're going to give them, if it's very severe, then you're going to give them buccal or IM prochlorperazine. And if it's not so severe, you can give them the ENE drugs. So it's PPCC or 2P2C. So prochlorperazine or promethazine, synerzine, and cyclizine. And bonus, these are the same 4 drugs that you give for hyperemesis gravidarum. Okay, if a terminally ill patient has bad breath or halitosis, then you're going to determine the cause. You're going to look at their mouth, and if they have any fungi, then you know that it's because of a fungus. Then you can give them an antifungal mouthwash or drops. To see the cause, you ask them to pinch the nose and breathe out through their mouth. If it's worse, then that means that the location is oral or pharyngeal. If that's not the case, then you ask them to exhale through the nose with the mouth closed. If it's more worse, then it's probably nasal. And if it's neither of them, then it's probably systemic. You see, when there is an infection going on, bacteria, they produce lots of gases, come out as bad breath. Okay, so the best way to treat this would be to giving them antibiotics, because that would reduce the bacterial activity and that would improve the bad breath. I forgot to mention there is another drug that we can use instead of hyoscine, which is called glycopyrronium bromide. So both of these are used for the respiratory secretions, and these are used when the patient has death rattles. The best treatment for a patient who is actively dying and they're not taking anything by mouth, what you do is you keep their mouth wet with small sponges. There are specific sponges, and you just keep their lips dry, you keep their mouth dry with small sips of water, and you just try and keep them comfortable just to make the death process easier. I know it feels like you want to do something, but honestly, this is what the guidelines say, and I'm just telling you what the algorithm is. Also, for constipation, you do not give lactulose in palliative care. Okay, it is the worst laxative to give because it causes more bloating and abdominal discomfort, so it just causes them more pain. So yeah, you do not give that. And if the patient is actively dying, you give them 2 drugs. You give them 10 milligrams each of subcutaneous midazolam and 10 milligrams of subcutaneous morphine. This reduces anxiety and this reduces pain, making it more comfortable for them. So, for example, if the patient has had a really bad bleed, or if they're actively bleeding and they're almost about to die, a terminal ill patient that is, you do not give them blood, you do not give them vitamin K, you do not give them fluids, you just give them midazolam and morphine subcutaneously. Normally, if a patient is a palliative patient, if their GP comes and sees them, they give them some anticipatory medications that are kept in the patient's house in case if the patient needs them. A nurse can come and administer those medications, and those medications they're all subcutaneous. So there's morphine sulfate, midazolam, haloperidol, and hyoscine butyl bromide. Okay, this is going to help with pain, breathlessness, nausea, vomiting, anxiety, agitation, and secretions. So for pain and breathlessness, morphine is given. For nausea and vomiting, haloperidol. For anxiety, midazolam. And for secretions, hyoscine butyl bromide. You really don't need to know the doses, but if you do, let me know. I'll include it in the description, or if I'm going to make this individual, I'll add it on the screen. Another important thing, if the patient has Parkinson's and you're trying to treat their nausea, then you do not give them metoclopramide and you do not give them haloperidol, because this makes their Parkinson's symptoms more worse. So a safe drug to use would be subcutaneous levomethomazine or cyclizine. Okay, if the patient has their GFR is less than 60, then you do not give them morphine. You give them alfentanil or oxycodone, not morphine, because it will be a lot of edema and it'll just cause more. It will just reduce the absorption of morphine. So yeah, if the GFR is given, they're definitely trying to make you think about this point. Okay, now if the patient has a cough, if they have a dry cough, you would go in a stepwise approach. First of all, you would try to humidify the air. If there's no response, then you give them a codeine syrup or tablets if they're able to take oral, and if there's no response, you give them morphine. You also give them an antiemetic and laxative just to help with the side effects of morphine. If that doesn't work, you seek a specialist advice, which will probably be nebulized lidocaine. You do not try this first line because it has an unpleasant taste and it can cause bronchoconstriction, and it has a really short duration of action. So that would be a specialized approach. For a moist or wet cough, you treat the underlying infection. If they're able to cough, then you give them a mucolytic or an expectorant to help them cough it out. You can also use nebulized saline. If they have a dry mouth, you can use humidified oxygen. If they're unable to cough, then you change their body position and you try to dry up the secretions. And if the cough is really, really bad, then you can give them morphine. And morphine is like the last line if nothing else is working, and if they're very, very weak and they can't even cough, then you give them morphine. The reason morphine is given because it suppresses the cough reflex. So yes, this was everything high yield palliative medicine. If there are some extra things that I remember after this, then I'll add them in the last slide. Hopefully this video helps you. This podcast helps you. Please let me know in the comments, and thank you for listening. I really, really hope this helps.